My pleasure now to introduce Dr. Daniel Ovakim. He's a critical care physician in Victoria, also a toxicologist working with BC Drug and Poison Information Control, and our regional medical director for organ donation in Vancouver Island. So,
hi, thank you, Sean. Okay, this is great. So I have the dubious honor of giving you a pharmacology lecture after a big lunch. So I hope you guys can stay awake for most of this. So I'm going to talk about the confounders to death by neurologic criteria, but also trying to explain how the toxic drug crisis that we're dealing with in BC right now and across the country may make this a bit more complicated. So I'm going to start off, I'm going to go over generalities of ICU patients and the variables that can affect how all drugs, both therapeutic and recreational, are affected by critical illness. I'll describe the novel psychoactive drugs that are out there in the community right now. And then I'll review how the limitations and the recent recommendations around eliminating confounders might be problematic in the area of this toxic drug crisis. And then try to come up with an approach, how we can approach the exam in these patients. I have no relevant disclosures to speak about. So in terms of approaching death by neurologic criteria, the principles for all organ donation is that death must be determined with absolute certainty, obviously. But for death by neurologic criteria, we need to prove that the absence of brain function that we find in our exam is a result of a brain injury, not the result of a residual drug or toxin effect. And the issues that we deal with is that we need to delay this clinical examination for brain death by ensuring that all drug effects have potentially dissipated. Now, this is difficult to predict in both the overdose, but also in a therapeutic setting. Number one, we have a hard time predicting what the effect of critical illness is on the disposition of drugs used in the ICU. And there are many uncharacterized drugs and toxins that may have led to our patient's admission to the ICU, either in the overdose scenario or presenting as a cardiac arrest from an overdose. So this is a prototypical case to go through. This is a 68-year-old male patient who was admitted to the ICU after an out-of-hospital cardiac arrest. He had a prolonged downtime prior to the return of circulation. Ended up being admitted to a community ICU and supported there, with the only past medical history being chronic pain with the list of medications that he takes there. No obvious or known history of recreational drug use. The initial CAT scan that he had on arrival demonstrated evidence of an early hypoxic ischemic brain injury. Very standard, common case. On the fourth hospital day in the referring hospital, he underwent a clinical exam for death by neurologic criteria, and it was revealing of no brainstem reflexes, but also a positive apnea test, thereby confirming a diagnosis of brain death with no obvious confounders. The drugs that he received in the ICU are listed there, mainly propofol infusions, fentanyl and midazolam infusions, very commonplace drugs, all of which were stopped roughly 6 hours prior to proceeding with the exam. On the seventh hospital day, he was transferred to a tertiary hospital for organ retrieval. However, when the patient arrived, he was noted to be taking spontaneous breaths on the ventilator. So going against the positive apnea test. The next day, he was re-examined. He underwent a nuclear medicine scan, which demonstrated flow, intracranial blood flow, and the exam was no longer consistent with death by neurologic criteria. Thereafter, he was referred for a DCD procurement. So questions from this case that came up, well, what happened with the initial exam for your brain death? Is it an experience issue with the referring center? Was there other possible confounders that we were not aware of, although everything else was normal, blood work, et cetera? Or were we dealing with an overdose scenario that we just didn't know about on history? And if so, what was the agent that the patient overdosed on? Or was there something to do with the patient that he just wasn't clearing drugs properly? And these remain to be unknowns. So the two scenarios I'm going to try and cover through this talk, and because there's two quite separate clinical entities, it was hard to kind of put it all together to come up with one good story for all this. So we'll try and look at therapeutic use of drugs in the ICU and how alterations of drug metabolism can cause issues in terms of estimating when a drug is cleared. And that usually arises from us trying to apply normal drug pharmacokinetics and metabolism in normal humans to those in critically ill environments. But also in the overdose scenario, we have to deal with both pharmaceutical overdoses and recreational drug overdoses, plus this ever-evolving toxic drug pool with many new, novel, and uncharacterized drugs, and we don't really have a lot of data to guide management. So I'm going to start off and talk about drug disposition in the ICU. So what happens to medications that we give to our patients in the critical care environment? So the major players are going to be our CNS depressants. So these are our opioids, benzodiazepines, propofol, barbiturates, and ketamine. But there's other drugs that can also confound our exam. So the ones, I'll talk a bit about this later, but baclofen and bupropion are two agents that are known to potentially mimic brain death. And there are cases of toxic alcohols, so that's methanol and ethylene glycol, leading to this phenomenon, and antiepileptics, in particular valproic acid, but also the recreational drugs, mainly consisting of ultra-potent opioids and benzodiazepines, as well as other agents that we have no idea how they are metabolized or how long they last for, and have no idea what their effect is on the clinical exam. So if we look back at the basics of all clinical pharmacology and clinical pharmacokinetics, we need to look at clearance and the volume distribution, and I'll go through both of these. And these interact with one another, and together the two of them combine to come up with the drug's half-life. So how long it takes for the drug to be reduced to half of its level. And the half-life is what determines the duration of action and how long a drug will last for. Now, clearance is a description of how efficiently a drug is removed from the blood. And it's usually expressed as a unit of blood. How much of a unit of blood is cleared of that drug per unit of time. So for example, 30 mils per minute will be completely cleared of that drug per minute, okay? It's a funny construct, but that's how it's described. And for most drugs, that's an inherent characteristic. And it depends on a variety of factors. So it depends on your liver's drug metabolizing enzymes and how well they're functioning. Those are your cytochrome P450s or CYPs. It depends on hepatic extraction ratio, which describes how efficient the liver is at clearing a drug. So for example, a drug like morphine or lidocaine has a very high hepatic extraction ratio. That means it's, as long as the liver is working and there's good blood flow, that drug will be cleared very rapidly, okay? Whereas some drugs have a low hepatic extraction ratio, like warfarin, for example, or phenytoin, and they're usually bound to plasma proteins, and their clearance is dependent upon being bound to protein. So they tend to have longer half-lives, and they really need to be cleared by drug metabolizing enzymes. And the second thing we need to look at is how efficient the kidney is in removing this drug. So the kidney can either eliminate a parent drug or get rid of a metabolite of the drug. And those metabolites can be active metabolites or they can be inactive metabolites. The other concept of volume distribution is how the body contains the drug. So is it in the plasma? Is it in the fat tissues? Is it in other organs? And it's a parent space that contains the absorbed drug. And you can look at it as a volume necessary to contain all of the drug that's present in the body, as if it's the same concentration we find in the blood. It's an artificial construct that's meant to describe what happens to a drug once it's given to a patient. So if a drug has a low volume distribution, that means it stays in the plasma and highly perfused organs, mainly the liver and the kidney. For drugs that are highly distributed, so a good example is fentanyl. This is a drug that leaves the plasma and enters the extravascular compartments. It's mainly going to be fat. Sometimes there's other tissues like skeletal muscle or the heart. So here's an example to try and explain the volume distribution. So each of the containers on the left and the right is a central compartment. So it has 1,000 milliliters in the central compartment, which is your blood and your highly perfused organs. On the right is a example showing the peripheral compartment, so adipose tissue, okay? So if I take drug number 1 on the left there, and it's hydrophilic, so it stays in the plasma because it likes to be dissolved in water. If I administer that full 1,000 milligrams into the 1,000 milliliters of the central compartment, it'll be dissolved evenly and stays there. So if I measured a sample from there, it'll take all 1,000 milligrams will be dissolved in the 1,000 mils, giving me a concentration of 1 milligram per mil. If I want to calculate the volume distribution, I can say that, well, that drug distributes across that 1 liter, therefore the distribution volume is 1,000 milliliters or 1 liter, because it all stays in the plasma. A drug that behaves like that is aspirin, for example. Okay, so drug number 2 is a lipophilic drug. A lot of our sedatives, a lot of our opioids are very lipophilic, and they distribute through the adipose tissue. So if I give a bolus of that drug into the patient, it'll go to the blood, but after some time, most of that drug will move into the fat stores. And let's say in this case, 90% of that drug goes to the fat, which is what happens with fentanyl, for example. So if I measure that sample, I'll say, well, there's 100 milligrams left dissolved in that 1,000 mils of the blood that I'm measuring. We can't measure the concentration of drugs in the fat, Okay, we can only measure the blood. So therefore, if I apply the same calculations, it'll appear as though that drug is dissolved in 10,000 milliliters, okay? Which is why if you look at a drug like amiodarone, it has a distribution volume of 300 liters. Well, there's no human that is 300 liters, but it appears to be that way because so much of that drug leaves the blood and enters the fat and other tissues. So this all leads to trying to figure out what a drug's half-life is, right? So half-life is going to be context sensitive. I'll explain that later. It varies in our patients because of many factors related to the patient, to the disease that they might have that they're admitted with, and what we do to the patient, so treatment factors. And the variability is significant, and whatever we know as a published half-life comes from healthy volunteers, healthy volunteer patients with no organ dysfunctions or issues with fluid status and whatnot. Okay, so there are many things that affect our patients in ICU. So the first half of that problem is things that prolong the half-life. Okay, so you're either going to prolong a drug's half-life by interfering with their clearance. So that's going to be major organ dysfunction, so liver dysfunction or kidney dysfunction, drug interactions, and older patients just don't clear drug as fast as younger patients do. Then we also have a number of things that we do that increase the volume distribution. So loss of fluid causes drugs that are hydrophilic, for example, to go into the third space with the fluid that we administer. Patients that might be on ECMO, so extracorporeal treatment, have a larger volume distribution. Obesity, I'll explain that a bit later, and then prolonged infusions, which I'll also talk about a bit later. On the second half of those things that shorten half-life, things that we don't really tend to worry about too much because that might be in our favor, but patients who have increased clearance are patients that are on vasopressors, for example, they have hyperdynamic states, such as a brain injury or a trauma, and also some drug-drug interactions. And then finally, there are a couple of things that reduce the distributed volume of a drug. That would be hemodialysis and aggressive diuresis, where we contract their total plasma volume. So we're going to look at some patient factors, some disease-related factors, and some treatment-related factors that do interfere with our ability to clear drugs. So end organ dysfunction. So as I said earlier, we're looking at liver and kidney. I'll give you an example of hydromorphone, very popular drug used as bolus and infusions. So hydromorphone depends on the liver for metabolism. It gets metabolized to both active metabolites and inactive metabolites. And both the parent drug, hydromorphone, and the metabolites need to be cleared by the kidney. But in the disease states, you might find you accumulate hydromorphone, you accumulate the active metabolites. If the kidneys have failed as well, they'll be clear less, and the patient just doesn't wake up. Okay, that's a very common scenario. In patients that are obese, that tends to affect how lipids will accumulate drugs. So most sedatives are very lipophilic. This is necessary because the brain is very fatty organ, so you need to have lipids to get into the brain, or drug needs to be lipophilic to get into the brain where you want it to work. But as a result of this, the adipose tissue acts as a drug reservoir. And the drug, even though the infusion might be discontinued, the drug will slowly be released into the blood despite discontinuation. We have no idea how long this takes or how to predict this. As a result, you end up with a higher distribution volume and a very prolonged clearance, and therefore a larger half-life. So whatever you're reading about as a published half-life for a particular drug may not be necessarily true. If we look at the effect of illness itself on how drugs are cleared, many drugs are bound to protein. A good example is warfarin, phenytoin, and fentanyl. They're all bound to protein at high levels. If the patient has impaired liver dysfunction and their albumin levels are low, or they're sick and their albumin levels are low, then they have a higher free fraction of drugs, so there's less protein to bind that drug. So that might make the drug get cleared a bit faster. It's probably insignificant. I talked about fluid administration and the third spacing that occurs, and it'll increase the volume distribution for hydrophilic drugs. Patients that are in shock would have reduced hepatic blood flow, which slows down the clearance of drugs that are dependent upon hepatic blood flow, so the high extraction ratio drugs. And anything that's going to increase clearance because of augmented renal hemodynamics. So vasopressors, patients who have burns, brain injury, or polytrauma, they tend to be hyperdynamic and chew through things a bit faster. Now, about the things that we do to patients. So the biggest one I think that is largely underappreciated or known about but not really cared about is the context-sensitive half-life. Okay, and this is also known as the context-sensitive half-time. And this is the half-life of a drug after it's been discontinued following a continuous infusion. And this is a change in the half-life of a drug the longer it's infused continuously. And this varies as a function of the duration of the infusion. So the longer the patient's on the infusion, the longer the half-life. And this is a result of a significant increase in the volume of distribution for drugs that are lipophilic. This is what I call the myth of the short-acting drugs in the ICU. Fentanyl and midazolam are very popular in critical care. We use them for ventilation, for a variety of things. We think that these drugs are short-acting, so it allows for a quick onset, quick offset. And however, these presumptions are incorrect in most settings because after 1 or 2 hours of a continuous infusion, the drugs will leave the blood and enter the fat, and they stay there. And then once you stop the infusion, they have to be eliminated, but they're still there. So if you look at this graph here, as an example of the context-sensitive half-life for a variety of different drugs we use in critical care. Unfortunately, the ideal drug in the bottom there, remifentanil, we can't get in critical care because it's too expensive. But if you look at fentanyl, the half-life of fentanyl goes up extremely high after about 3 hours of an infusion as the fentanyl moves from the plasma into the fat. Right? And some cases have shown that the half-life of fentanyl, which is published at 2 to 4 hours, in non-critical patients. So if I'm getting my shoulder reduced in the emergency department and I get a dose of fentanyl, that goes away in a couple hours. But in some patients in critical care, it's been up to 25 hours they found the half-life of fentanyl to be, just by simply continuing the infusion. Drug interactions is not a common problem in critical care, fortunately. You can, in theory, induce drug metabolizing enzymes by certain drugs. So occasionally we do use rifampin. We often do use barbiturates for bad cases of alcohol withdrawal. And this can induce other drugs to be metabolized faster. And this can lead to therapeutic failure of antibiotics and other agents. But more significantly are the drugs that can interfere with the drug metabolizing enzymes. So that create toxicity. So many antifungal agents, some antibiotics can block most drug metabolizing enzymes, lead to accumulation of sedatives and other agents. I mentioned earlier about ECMO, and ECMO being a circuit used to support circulation of patients in cardiogenic shock. And this effectively increases the volume distribution as it pulls blood out of the patient. Whether or not this has increased significance or whether or not this is significant is unclear. As well as continual renal replacement therapy, hemodialysis. It does clear some metabolites of some drugs, but probably doesn't clear much and many others, especially if a drug is highly bound to fat or if it is highly bound to protein, it won't clear those drugs. So it may not make much of a difference. Hypothermia, now both due to injury or exposure while intoxicated, or iatrogenic, so post-cardiac arrest, although I don't think most centers do this anymore, but that actually slows down many factors of drug metabolism. If patients have ingested something, then it would slow down the absorption. However, what it does is known to shut down the rate of drug metabolizing enzymes, so therefore it'll delay the clearance of drugs that are dependent upon drug metabolizing enzymes to clear. So that would be the drugs that have a low hepatic extraction ratio. Fentanyl and propofol is good examples. Fentanyl is highly bound to protein, needs to be cleared by the enzymes through the liver. But if those enzymes are slowed down, it's going to hang around even longer, in addition to the accumulation of fat it's already experienced. Okay, so I'll spend a bit of time talking about the toxic drug pool, and formerly known as the novel psychoactive substances, i.e. more than just fentanyl. So last year in British Columbia, there were approximately 2,400 deaths from illicit drug overdoses. 85% of those were due to fentanyl or fentanyl analogs, so variants of fentanyl, but it's all included in the same group. Some of these patients were deaths that included patients with anoxic brain injury post-arrest that were taken off life support. And these patients are very well young and healthy patients and considered appropriate donor candidates. So data for British Columbia is seen there. This is up until August of this year. This is from the BC Coroner Service. You can see there was a bit of a dip in 2019, of course, and then when COVID hit, things got incrementally worse. And you can see I mentioned earlier that about 85% of these deaths are due to fentanyl, and this is fentanyl analogs. And this has been pretty consistent now for the last 5 or 6 years, where about 85% of all deaths had fentanyl involved. So in addition to fentanyl, however, there's many other toxic substances that have entered the drug pool. Why did this happen? I don't know the real reasons why this happened, but largely I think it's because of limited availability of fentanyl during the COVID shutdown. So people had to get creative. Just prior to the COVID pandemic, there were some changes at the Canada Customs and and Canada Post with how they handle mail coming from China. So they're able to search it for fentanyl where they couldn't do that before. So I think it's being picked up at the borders more. And but during the COVID, that kind of got shut down because the borders were shut down. There's competition continuously for better drug experiences, better highs, etc. There's manufacturer inexperience. Not every drug manufacturer is Walter White from Breaking Bad. They just don't know what they're doing. Okay, so a lot of it's going to be inadvertent contamination. So there's the United Nations Office on Drug and Crime that keeps track of all these things. And since 2013, so in 10 years, there have been about 1,200 different drugs have been identified, and they can be broken down into 6 different categories. Dissociatives are drugs like ketamine and PCP. Sedative hypnotics are mainly benzodiazepines. Stimulants are going to be your methamphetamines, your bath salts, so the cathinones and cocaine. Hallucinogens, LSD, synthetic opioids, we'll talk a bit about that, and synthetic cannabinoid receptor agonists. Now, we don't really have those in Canada because we have plenty of natural cannabinoids around to make everybody happy, so we don't see those much in Canada. And the data on the graph on the right there are showing all the different drugs that have been seen. And mainly it's going to be sedatives up there, but that's international data. Opioids is really a North American phenomenon, Canada and the United States primarily. In British Columbia, the novel substances that we tend to pick up are fentanyl and fentanyl analogs predominate, as well as stimulants. And the situation here is I think the stimulant pool has now been contaminated with fentanyl and fentanyl analogs, whereas previously that wasn't much of a problem. Benzodiazepines aren't as common as they are in other jurisdictions, but they are ending up in our drug pool. I'll talk about that in a minute. And just a brief coverage of all the substances that are detected in unregulated drug deaths in British Columbia. Most of it's going to be fentanyl, unsurprising. And you see cocaine and methamphetamine there are the second and the third most common, and I suspect those are probably adulterated adulterated cocaine and methamphetamine, i.e. they're contaminated with fentanyl and other products. And then a smattering of other drugs there. So what are these agents? What's the definitions we'll spend some time talking about? What are cutting agents? So you have 3 different things. You have a contaminant, which is a byproduct of the manufacturing process. Making cocaine is not a very clean process. It involves gasoline and a bunch of other chemicals. So there's contaminants. So these are nasty chemicals that can cause problems. There's adulterants. So these are pharmacologically active substances that are given to add either a synergistic or an antagonistic effect of the drug. So for example, all cocaine in North America now contains a chemical called levamisole, which is a pig dewormer. The reason it's used in cocaine is 2. 1, it passes the cutting test. So when it comes to North America from Colombia, they can test to see if it's been cut with something, and it doesn't show up as being cut. So it passes that cutting test. And therefore, it creates less decapitations in Mexico when they're sending them cut cocaine. But levamisole gets metabolized to a stimulant called Aminorex, which is just a fluke of chemistry that it actually adds to the cocaine effect. And then there are diluents. So these are things that are added to the cocaine to increase the bulk. So any white powder, for example, could be added to a drug to increase the bulk. That's more of a drug economics point of view. Okay, so they're usually inert. So what's happened is that what used to be called heroin, or used to be heroin, straightforward heroin, are largely contaminated now with synthetic opioids, so fentanyl and fentanyl analogs, and these are produced in labs. Most of the precursors come from China, and now a lot of it comes from Mexico. And they're either manufactured or altered in Canada or in Mexico and the States as well. So this is largely what is the heroin out there today, and largely what the recreational opioid is. It's very easy to acquire and smuggle. You can send an envelope with 20 grams of fentanyl across the country, which is about 50,000 doses worth of fentanyl in a little envelope, right? So it's very potent. Carfentanil made its way a number of years ago. It's a fentanyl analog that's used in veterinary medicine. And was first added to heroin in 2016, and we first saw it in Canada around that time. It's extraordinarily potent. You can buy it off the dark web. I had my son actually enter the dark web and try to order some, not for reasons, personal reasons, just to see how easy it was to use, to get, and you can order it online for like $100. And it's 10,000 times the potency of morphine and about 30 times the potency of fentanyl. The interesting is that no one really knows the pharmacokinetics of it. It apparently has a half-life up to 12 hours, but also can enter the fat and then re-exit the fat and re-narcotize the patient after a single dose. So it's quite dangerous in that regard. What's now entering the market, and you could also get on the dark web, are the nitazines, which are super ultra synthetic opioids that were used as research chemicals to study the opioid receptor. And it's in Canada now. It's not currently detected by any tests that we have available to us. And I'll go through the testing in a minute. There are many analogs of these drugs, and they're extremely potent, but they do and they should respond to naloxone as they are opioids. But you likely need higher doses. Now, the benzodiazepines is a pickle. Because why did benzodiazepines enter into the toxic opioid pool or the heroin pool? Now, these are ultra potent benzos. So atizolam and flubrorazepam are the most common ones. It's probably in about 45% of all illicit opioids. And these are patients that are going to be found down and not respond to naloxone. And then the latest one is xylazine, which is a very potent alpha-2 agonist, so very similar to clonidine or dexmedetomidine. And it's veterinary. It's used to sedate horses, and it can cause significant sedation, but also bradycardia and hypotension, which might be clues to its presence. And it also might respond to high doses of naloxone for the CNS effects, but super high doses. And just a bit about the stimulants. So fentanyl and fentanyl analogs haven't really ended up in the stimulant pool up until the last couple of years. It's not clear why this has happened, but it seems to be leading to inadvertent opioid overdoses in opioid-naive users. People who are faithful to cocaine might be inadvertently overdosed to opioids that they're not used to. Okay, so what do we do with all these drugs, and how do we rule out their effects on our patients? So I showed a slide at the beginning, highlighting again that the exam should be delayed until we're sure that any drug effect has been eliminated, has dissipated. And it's difficult to predict this because of the changes we went through about the pharmacokinetics in patients, but also these new drugs that are out there. If we look at the recent recommendations that have come out earlier this year, in both Canadian recommendations and in the US, there's two types of confounders. There's the therapeutic ones that we give our patients to help manage them in the ICU. So these are sedatives and opioids. And then there are drugs that are taken in the overdose setting. So there's the recreational drugs, there's ethanol, and then there's pharmaceuticals that can cause problems. So what the recommendations are is to do a blood and a urine toxicology screen that are used diagnostically to identify drugs. I put the word diagnostically in italics for a reason. Therapeutic levels of drugs are not considered confounding. So if a patient's on fentanyl and midazolam infusions, those aren't considered confounding. I don't necessarily think that's reasonable. I think they should be stopped. Alcohol levels should be below the legal limit, which is 80 milligrams per deciliter, or otherwise in Canada known as 17 millimoles per liter. And you need to wait 5 half-lives for a drug before assessing death by neurologic criteria. And I'll go through that in a second. And if there's any uncertainty at all, whatever the confounder may be, you would pursue ancillary testing. So limitations, are going to spend a moment talking about toxicology screens, where we talk about measuring drug levels. I talked already about the pharmacokinetics, and we spent the last section talking about the novel drugs. So in terms of toxicology screens and why I find this as a major limitation, the urine drug screen is an interesting test. It's often part of a standard workup for an unconscious patient. Okay, and this is a urine immunoassay. It uses antibodies to detect known metabolites of common drugs. Right? Different hospitals have different immunoassays that they use. There are many false positives and many false negatives, and there are many, many, many misconceptions. Number one, is that test for everything. No, it doesn't. That novel drugs will be detected. No, they won't. That positive on your urine drug screen said that's why the patient's unconscious. No, it doesn't. And a negative suggests that nothing is there. That's wrong. They are not diagnostic at all, okay? They're for truck drivers and pilots to make sure that they're not driving a truck or flying a plane while intoxicated, okay? It is probably the one test that gives the least useful information, but that generates the most diagnostic confidence, okay? A negative screen does not mean a patient's not intoxicated. A positive screen does not tell you how intoxicated they are, okay? And 2 rules. But what about advanced testing? Well, we do have liquid chromatography and mass spectroscopy available, right? This is something we can do to get a comprehensive qualitative test. There's much, the specificity is improved. It detects many novel agents, but not all of them. But it's a very long turnaround time, 2 to 3 days. 2 to 3 days in an ICU patient with an anoxic brain injury and a family in torment is a long time, okay? We don't really have a good process for ordering this test. I can order it every day on the same patient, and they'll just keep repeating the same urine drug screen at the beginning, okay? Because you have to specifically order it, but somewhere down the line gets misinterpreted as just repeating the urine drug screen. And there's only a couple labs. We have a lab in Victoria, and there's a lab in Vancouver that does it, but it's hard to get. But you can, right? You can go to the Provincial Toxicology Lab website. You can go to their website. You can type in UDS 137, right? Urine drug screen 137. And you get a list of all a bunch of things that this will test, right? Test 32 different benzodiazepines, 39 different opioids, and other drugs. The other drugs include xylazine, ketamine, all the other sedatives we talked about. Okay, and you can order this, you can download the rec and have it sent off on your patient in your unit, okay? And they say the turnaround time is 7 days, but it's usually done a lot faster, but probably 2 or 3 days. Maybe it's something to do at the beginning of your patient being admitted, so by the time you're having these discussions about removal of life support, you have this information available. What about blood levels? Well, you can get blood levels for specific drugs like salicylates, acetaminophen, and ethanol, but those aren't really confounders per se. You can check for the toxic alcohols, but usually you'll know someone has a toxic alcohol confounder because they'll have severe acidosis or something like that, right? It's not usually subtle. And you can measure valproic acid, measure phenytoin and barbiturates. Those will be very unusual causes of brain death, and you might have you'd be on your differential as part of the presentation. But what about everything else? What about the drugs that we actually use as therapies in the ICU? Well, we don't really have any quantitative levels that are available outside of research settings. There was a nice study done in Quebec where they looked at developing an assay that uses mass spec and liquid chromatography to look for common drugs and sedatives we use in the ICU, but it's still in its infancy. It's not widely available, and it's extremely expensive to do it on every single patient. So when we get to that whole idea of how long to wait for, well, you need to wait for 5 half-lives. Well, 5 half-lives, if you think about it, 5 half-lives will take you down to about 3% of the original drug level. Well, that's great, that's well and good if they took a Tylenol, right? But half-life comes from healthy volunteers. So I've spent the last 32 minutes talking about how unpredictable this is in our critically ill patients. And if it's an overdose scenario, toxicokinetics and toxicodynamics are completely different in the overdose scenario. And 3% of an initial level of something that's massive will still be pharmacologically active. So someone overdosed on some fentanyl analog at 16 times the therapeutic dose, it may still potentially be sedating at that 5 half-life time that we calculate. And if you have an unknown substance that's available, how do you know what the half-life is? So the current approach is good in most scenarios, but it's a bit flawed because ruling out residual drug effect is the best estimate. And waiting 5 half-lives, I think in most cases, will underestimate how much you actually need to wait for the drug to wear off. In the therapeutic scenario, it's all guesswork to guess how a drug is going to behave in our patient. Sure, there might be 2 factors that are slowing down the clearance and 2 factors that are raising the clearance, but we don't know enough, we don't have the math to reconcile that. And in the overdose, I think it's all of a wash because we can't test for things in most scenarios. And there's an ever-evolving drug pool that we can't predict. So then what do we do if we want to approach the brain death exam in an overdose setting, for example? Now, in terms of the guidance we have for reversible brain death, we have 10 cases that we have in the literature since 2007. 3 of them have been baclofen, one of which was a patient that woke up on the table when their organs were about to be procured. That's fortunately the anesthesiologist was paying attention. So 3 of those have been bupropion, which is, I can tell you from my other life as a toxicologist, it's extremely common overdose. And the ones that we have that have been reported, fortunately for bupropion and amitriptyline, for example, we do have the liquid chromatography assay will pick that up. It's a metabolite of bupropion that we measure, which is the problematic chemical. We can get blood levels of valproic acid and toxic alcohols. But for the rest, we don't really have much we can do. And there really been no reported cases in the literature of opioids or benzodiazepines causing a false positive brain death exam, but doesn't mean it can't confound it. So the issues when we're approaching this is the patient obtunded or in a coma because of ongoing drug intoxication? Do we wait long enough for this drug to clear? Is there any features of this patient to suggest that maybe they're not clearing drugs properly? Or is it much impaired for whatever reason? Or should we just go and do ancillary testing because we're not going to be able to answer the first 3 questions? So we talked about blood work already in terms of things we need to consider when approaching this. And we'll spend a bit of time talking about time, imaging, considering reversal agents, and then moving on to ancillary testing. So when we think about time, number one, the optimal time to wait for drug clearance is not known. I think I've explained that. I hope I've explained that. Okay. The time that we can wait for these things to dissipate, maybe 6 to 10 days, I think it's probably a ballpark. That's a safe way to assume drugs are gone. Isn't practical because 10 days is a long time to support a potential organ donor. They can get very unstable, get a whole host of the complications that can happen in ICU. And this is painful for the families to wait that long to make a decision. So we have neuroimaging to go by. The CT scan might be normal initially in the early phases after an overdose or cardiac arrest. We might see initial loss of gray white differentiation that might be non-specific, but we'll get follow-up scans. CTs are often followed by MRIs in 2 or 3 days if the patient fails to wake up. And this might help us counsel family depending on the findings. If it's normal, it might help you suggest it's not a major anoxic brain injury from the arrest, or might suggest that the exam findings are chemically related. If it's severely abnormal and diffuse abnormalities, you might suggest that there is irreversibility to it. So if the gray matter is hyperdense, or if there is irreversibility seen on diffusion-weighted imaging, this might suspect that there is a permanent loss of brain activity or of brain tissue. So this may aid in decisions in approaching withdrawal of life support. But the MRIs can be challenging. Sometimes we interpret the white matter abnormalities. This might as irreversible. It may actually be reversible, right? So that might be a problem. So patients, for example, that are post carbon monoxide exposure or who have inhaled drugs like smoked fentanyl, they can get a post-anoxic leukoencephalopathy, which is theoretically treatable. So white matter findings we're finding on MRI may be fixable. In patients who have opioid overdoses, after we fix their hypoxemia and the hypotension, they might have some white matter swelling, which may actually be reversible, but could be interpreted as an anoxic brain injury. So that poses some challenges. I'm not a radiologist or a neurologist, but as far as I know, that can be pretty challenging. So then we're left with considering reversal agents. Well, why don't we just give these patients a giant dose of naloxone to help reverse the opioids? Well, I've done this before clinically, and it's never worked because it's, but I have had cases where patients have been sedated for many, many days, and you give them a dose of naloxone, and they start to move. And this is not a post-arrest scenario per se, but the newer synthetic opioids and xylazine may respond to naloxone, but require higher doses, 10 to 15, 20 milligrams perhaps. In the early stages, so what I mean in the first 24 hours or so, I wouldn't probably do that because you could theoretically induce a seizure or pulmonary edema in patients from the acute opioid reversal. Flumazenol is very controversial. It's controversial in any scenario. It's something that toxicologists like to use to thumb their nose at people when they suggest it, although it's probably not that bad, but I'm telling you when I told you that. It has an unclear role in anoxic brain injury, hasn't really been tested. In the early stages of an overdose, benzodiazepines might be protecting you from another co-ingestant like a stimulant. So if a patient took a combination of heavy use of meth or cocaine and a benzo, it may actually be protecting them. So we tend not to recommend at the early stages. But in patients on a prolonged benzodiazepine infusion that's been shut off, it might be helpful and somewhat diagnostic to give a dose of flumazenol to see if you can partially reverse it. But in patients who are chronic benzodiazepine users, you may induce a seizure. Okay, someone with a bad anoxic brain injury, not likely to induce a seizure in that case, perhaps. But if you are approaching using flumazenol, it might be worthwhile having a syringe of propofol at the ready in case they do seize. Remember, benzodiazepines won't work because you just gave them a big dose of flumazenol. So it's important to have that preparation. But I think, unfortunately, in many of these cases, I could have saved this whole talk by just showing the slide for an ancillary test. So we just do flow studies and mainly nuclear medicine scans and soon to be CT angiogram and CT perfusion. Drug intoxication alone should not shut down cerebral blood flow. No matter how intoxicated they are, there should still be cerebral blood flow. So an ancillary test might be helpful in this scenario. And I think if you can't reliably exclude all the confounders and you've done a good physical examination, you should go ahead and do these tests or do an ancillary test. So put together this complicated flow sheet here, but I think it's important just to start at the GCS less than 5. So you have your patient who's either severe arrest or a severe overdose or cardiac arrest and an overdose. You support them for 2 to 3 days. you turn off the sedation, and they're still not waking up. And the approach there can be a bit difficult. If you can pursue neuroimaging, in most situations you will pursue neuroimaging. I think that if we can find a way to get a early comprehensive urine drug screen on the patient, that might be helpful, because by the time we're looking at prognostication, we might have the results available. I know where I work in Victoria, if someone has a positive fentanyl screen on their urine assay at the beginning, it'll automatically trigger a comprehensive test. That's not universal, I don't think. If the neuroimaging suggests severe anoxic brain injury, then I think pursuing with the physical examination for DNC is reasonable. I do think administering a dose of flumazenil or naloxone could be something to consider. I don't think it's valid. It's mandatory, but it's something to consider. But in most of these cases, I think that if the patient is brain dead on your examination, that pursuing an ancillary test is probably reasonable, unless the imaging is very devastating, like herniated, complete loss of gray white differentiation, or that like. But in either case, if they respond to the reversal agent, or if the examination is not consistent with a severe or not consistent with brain death, then discussions with family, consideration of withdrawal, and approaching DCD if that's the plan. Okay, so a couple things to say as I finish is that it's really hard to estimate how critical illness affects drug disposition, and most of it's going to be guesswork. The toxic drug pool and how it's changing on a day-by-day basis makes prognostication a bit more difficult and confidence in your exam a bit more difficult. So I think by using time, imaging, and judicious use of ancillary testing in addition to the full clinical examination whenever possible is probably the safest approach for these patients. And time for questions, I think. Sean? Yeah. Okay.
Anybody have questions for Daniel here? There's also a Slido for those I can access the Slido.
Yeah. Thank you for staying awake for the pharmacology part of it.
Yeah. And I know in my role, I get called at times and by our coordinators, and one of the two main things I get called about is, do we need ancillary testing? You know, and I think the calls are less and less because I think people are doing it. Mm. But there is always this desire to try to see if we can avoid it by waiting or just theorizing. And I do think a lot of people believe the urine test as a way of kind of giving them some indication of what happened to the person. So
yeah. Mm-hmm.
Yeah.
Any questions in here? Okay.
Okay.
Good.
Thank you, Daniel.
Yeah,
Great summary. Appreciate that.